So part two of infectious disease for the nurse practitioner. Just to review quickly a little bit around enteric diseases. Oftentimes you'll have patients come in and they'll have diarrhea. If it's short-term diarrhea, there's probably no need to really test for enteric diseases. If somebody has had diarrhea for a prolonged period of time, then sometimes it is useful to go ahead and test. Things that can cause these kinds of things: Salmonella, most commonly thought of as being associated with eggs or poorly cooked chicken, also related to certain pets, including turtles. Salmonella is a bacteria which is probably best left untreated. Unfortunately, a number of people who are treated for Salmonella will actually go chronic. If one has severe symptoms, then it is necessary to treat for Salmonella. Shiga toxin are producing E. coli infections. These are the E. coli type infections that cause substantial amount of rectal bleeding. This is not usually a subtle presentation. These folks are having pretty dramatic symptoms, and again, if you're having a substantial amount of blood in the stool and it is associated with diarrhea and you're thinking infection, then it is probably worth getting some testing done. Shigella is another infection that can occur. Again, can cause a pretty dramatic diarrhea, usually self-limiting. Most of these infections will actually respond to Cipro, but not all. Campylobacter is a less common one, seen rarely, often doesn't respond to Cipro, but will usually respond to Zithromax. Does usually show up on a stool culture. Not critical to diagnose in the first few days by any means, because most patients can tolerate a week or so of diarrhea. But if you have somebody that has persistent diarrhea, it's not getting better, then it might be worth culturing. Cryptosporidia is a protozoal infection. Generally, this is only seen in HIV patients and people that are immunosuppressed. It is a protozoa, so obviously would not respond to the usual antibacterial approaches. Need to test specifically looking for this. Giardia is another protozoa. Fortunately, there are PCR type tests that can test for Giardia and Cryptosporidium, so you do not necessarily want to get a culture. In the old days, we used to get stools for ova and parasites. Fortunately, that's pretty rarely needed anymore, just because the majority of things that produce ova and our parasites are able to be tested for in a different way. Norovirus is a very common cause of diarrhea, along with rotavirus. Rarely diagnosed other than by clinical grounds. If someone is real sick or if there is an outbreak, the CDC may get involved and do testing. However, it usually is something that is just found as a self-limiting viral illness. Listeria, unusual disease, usually self-limiting. Again, if one has diarrhea and one is starting to get meningeal signs, then it's probably important to test for Listeria. Most of these patients will be in the emergency room or in the hospital. So what kind of testing does one do when one has diarrhea? The stool culture is, again, of, I think, limited value until someone's had diarrhea for several weeks. The majority of things are self-limiting, do not need treatment. There's actually multiple media that can be used, and so if you're looking for a specific thing, for example, Campylobacter, you really do need to stipulate that that's what you're looking for, and then they'll use a medium that would grow that out. Some people will go ahead and get stools for white blood cells. This will support a bacterial cause of the diarrhea as opposed to a viral cause. However, E. coli does not usually produce white blood cells in the stool, and it's a rather non-specific finding. As noted, ovarian parasites, in my opinion, should be used very rarely. And then again, there are specific antigen tests. So UpToDate also has great misgivings about the use of stool cultures. There are a small group of people, however, who probably should have stool cultures on initial presentation. And so that is the HIV-infected patient, patients with dramatic comorbidities, severe inflammatory diarrhea, including a very bloody diarrhea. If there is inflammatory bowel disease, and you're really trying to decide whether this is a flare, whether this is infection, and if there is public health reasons for testing, such as in food handlers, then it is important to test those folks. Again, ovarian parasites, for the majority of patients, it's not a cost-effective test. If you have someone that has persistent diarrhea, and again, this will not test for bacterial causes of diarrhea. This only tests for parasites, several of which are much better tested now with specific antigen tests. So Giardia and Cryptosporidium usually can be tested by antigens. Amoeba is a little harder to identify, although those patients usually are not real sick. They just will have a persistent diarrhea. If one has been traveling, of course, there's a very different situation, and then you have to really look and see where they've been traveling to. If there is diarrhea that's related to traveling to Russia, Nepal, or the mountainous regions around them, then you may want to go ahead and do ovarian parasites. If there is a lot of people in a daycare, then it may be appropriate to test for ONP, although again, generally you're going to do the antigen tests. In men that have sex with men, or a patient with AIDS, Entamoeba histolytica is more common, and thus might be an indication for ONP testing. If there's a community waterborne outbreak, then again, you may want some testing, but again, you probably have better tests. And then if you've got bloody diarrhea and there's no white cells, then amoeba is on your differential, although it's a pretty unusual thing. I think I've seen one case in 30 years. The bloody diarrhea is, again, C. diff can be a bloody diarrhea, so make sure that you have ruled that out before you really start using any sort of antibiotic approaches. Usually patients will have had recent antibiotics, but not always. The E. coli, which is associated with substantial inflammation. And then if you have a Salmonella, Shigella, or Campylobacter infection, they can cause bloody diarrhea if they're bad enough. Don't forget that most cases of bloody diarrhea are going to be related to inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, but you know, keep in mind the infectious causes as well. So going back to Salmonella, E. coli, and Shigella, as we know, they're fecal-oral. The usual symptoms are pretty much the same for all these kinds of infections: diarrhea, nausea, vomiting, cramps, bloody stools, and fever. In those folks, if it has been long enough, you can do a stool culture. There is a type of test that can be done at the state lab looking specifically for them. But again, in the majority of cases, these are going to be self-limiting diseases. The exception, of course, is, again, a really sick patient or really substantial blood. So in food service workers, then obviously they can't work until they've had a negative culture. Symptomatic children in a daycare, pretty much the same thing. And hand hygiene is always a good idea. When I was an infection control practitioner, I spent days asking people to wash their hands. So, and again, you know, if foods are cooked properly, the incidence is less. Again, listeria is probably more common than any of us really realize. We only usually diagnose it if the patient is really, really sick, to the point of being in the ICU kind of thing. If you have a febrile gastroenteritis in pregnant women, then that is one of the possibilities, and you probably want to involve OB and/or infectious disease. So diseases that are carried by animals, so-called zoonotic diseases. We'll talk about rabies in a minute. Toxo is a very non-specific, a little bit of nausea, a little bit of not feeling good, a little bit of malaise. The majority of patients that have toxoplasmosis we never diagnose. The issue, of course, is that if a pregnant woman gets toxo, then she can have birth defects associated with it. This is why pregnant women should not be handling cat feces or really be too intimately involved with cats. Psittacosis is a chlamydia type bacteria, so it's an atypical bacteria. When you have someone with a persistent cough, you do always want to remember to ask them if they have birds at home. If they do have birds, then like most chlamydia, doxycycline is a good choice for treating psittacosis. Leptospirosis is a flu-like illness. It lasts a long time usually. Doxy or amoxicillin may help those people. The vets are actually becoming more aware of this, and there's multiple strains of lepto. There is a vaccine for lepto, and the vets are really encouraging people to get it, but that's beyond our scope of practice, isn't it? Trichinosis is a very rare disease. Trichinosis is from uncooked pork. There's really only about 40 cases per year in the United States. Pork is usually cooked very thoroughly. The other thing you remember is that freezing will also kill the trichinella. So it's very rare, but again, something to think of. Hantavirus, these patients are really, really sick. It would be really rare. There have been cases in the United States, most of which have been very serious and fatal if they've been diagnosed. Just in a really sick patient, it's something to consider. Rabies is any bite exposure, so any animal that is not documented to be completely immunized against rabies. If there is saliva introduced to the broken skin, there is concern. If there is any exposure to bats, including if a child is asleep in a room and you can't be sure the bat did not come in contact with them, then you do need to treat them as if they've had an exposure to rabies. Rabies is not passed through blood, urine, or feces. It is only passed through saliva, so that is reassuring. If you have an animal that you suspect might have rabies, usually the first thing to do is to call the animal control officer for the town where the bite occurred. The animal control officer will usually contact the state, and folks will come and get that animal. Fish and Game will come get it if it's a wild animal, and transport that animal to the state lab. The animal does need to be sacrificed to test for rabies. In a wild animal, that's usually just the process. They just go ahead and do that. In a domestic animal, they'll usually observe and quarantine the animal for a period of time. So again, when in doubt, you can call the state, as well as possibly use other resources. So, as noted, the observation period for rabies is about 10 days, sometimes longer. And again, if the animal gets symptomatic at all, they'll euthanize the animal and then section their brain. They actually need to look at the sections of brain under the microscope to determine whether the animal is infected with rabies. If they section the brain and there's no evidence of rabies, there's nothing that needs to happen. If the animal tests positive or the animal's not available for testing, then we go ahead and we give rabies prophylaxis, usually with the HDCV vaccine. And if one has a bite that can be seen, rabies immune globulin is also half of it's infiltrated around the bite and half of it's given IM. And if there is a real exposure, even if there's not a bite, that's considered. Bioterrorist agents, again, these are things we're not hopefully ever going to see. Reassuring that the majority of them do respond to fairly simple antibiotics. Anthrax can happen, usually skin, but can also happen as a cough. Botulism, they'll have dramatic GI symptoms. This is what we worry about with honey in children under 1. Brucellosis, this is an undulant fever. It kind of comes and goes. Animals may get it, so there is great concern about that. It is probably something that occurs more often than we realize. There's probably a lot of these folks that are diagnosed as having chronic Lyme. They will usually eventually get better. The plague, obviously those people get really sick. They usually develop skin lesions called buboes, hence they call it the bubonic plague. There is also the pneumonic plague, in which the plague only affects the lungs. These usually respond to aminoglycosides, which have to be given intravenously, as well as doxycycline. Other bioterror things, Q fever, those folks usually are not super sick. They usually just get a flu-like illness, but it could be used if it was weaponized. Ricin poisoning, those folks usually get really sick and almost always die. Tularemia is an infection that occurs with mostly rabbits. And again, they get a flu-like illness and they will respond to antibiotics. And smallpox is pretty much eradicated from the earth, but there are some in labs somewhere. So there is fear that smallpox will recur. Those folks get fever, malaise, headaches, as well as skin lesions. Tuberculosis is a rare infectious disease, but if one has a persistent cough, especially if one has been to parts of the world where it's endemic, one would really want to at least do a chest x-ray to make sure they don't have active tuberculosis. There is the PPD that can be used, but there is also the IGRA test, IGRA, the quantiferon gold, the blood test that can also be done. That's probably better if someone's had the BCG vaccine, which we don't give here in the United States, but many places around the world do give BCG. Legionella is a serious illness in many people. I'll talk about that on the next slide. And then we'll also talk about the streps and the other resistant organisms. So Legionella is a waterborne illness, often just a lower respiratory infection, usually pneumonia. But if somebody has more GI or neuro-type symptoms, then it may be appropriate to test for Legionella. Many antibiotic works, although the penicillins and the cephalosporins do not. If one has a milder case of Legionella, they usually refer to that as Pontiac fever. It's usually, again, self-limiting unless they get substantial GI or neuro-type symptoms. For resistant organisms, the one that we all know is MRSA. MRSA is an infection which is usually fairly easy to treat. We just have to know it's MRSA and use the appropriate antibiotics. The majority of patients that I've seen over the years come in complaining of a spider bite, and that is the usual appearance. Lots of times people that have MRSA are colonized in their nose and in their groin. We used to try to cure that colonization. We now know that that's relatively futile, and generally we just resign ourselves to the fact that these people are colonized with MRSA and that we need to choose antibiotics to cover for that if they get an infection. The usual treatments are used, including exclusion from contact sports, This can be an issue because sometimes in wrestlers and other athletes that have a lot of physical contact, they will develop issues. Just a historical mention, MRSA back in the 1970s and early 80s, the only ones that were known were the 100 and 200 strains. Those were not sensitive to anything except vancomycin. And so the concern is that we weren't going to be able to treat them. Fortunately, the number of vancomycin-resistant Staph aureus and vancomycin intermediate resistance have really been very minimal, even in that almost 40-year time period. And plus, there's been a couple of other antibiotics that have come along to treat them, such as Zyvox and some of the newer ones. So as of right now, it's not a major issue. Hopefully there will not be major outbreaks again of the 100 and 200 strains. The 300 and 400 strains are very commonly sensitive to Bactrim, although sometimes you need to do 2 double-strength tablets twice a day. They're often sensitive to doxycycline, and sometimes the culture also shows that they're sensitive to a quinolone. Tuberculosis, as we mentioned, droplet airborne, chronic cough, bloody sputum is usually a really good flag that would suggest the need for testing. Chest x-ray usually has a classic appearance, which you can easily look up online. Those are cavitary lesions. And again, the gold standard for testing is actually a culture, but generally we'll do sputums for acid-fast bacillus, as well as doing the PPD or a blood test. Treatment of tuberculosis is usually 3 drugs, sometimes 4 drug. If you have somebody that has latent TB, generally we put them on at least 1 drug. This is coordinated through the tuberculosis control program through the state, as well as Maine Medical Center does have a tuberculosis clinic as well that you can refer those people to. Generally, you got to get them on some kind of treatment to make them less infectious, and if you really do suspect tuberculosis, then obviously give the CDC a call. Sexually transmitted infections, we'll talk about these with some other talks as well, but HIV is definitely something that if someone has exposure, you definitely want to test them for. Remember, the window period can be as much as 3 months, and don't make any assumptions about groups. HIV can happen in any group, even though it is more prevalent in some others. Chlamydia and gonorrhea are actually very easy to test for, especially in men now. We usually do the urine test. It's a dirty urine. They have to have not urinated for at least an hour. They don't clean themselves off first, and they make sure to pee the very first amount. It's not a midstream urine. It's actually the first amount that comes out. So they do need to be instructed. When I have women come in with UTI type symptoms, I ask my medical assistant to go ahead and do a urine. With men, I do not, just because if you've done a regular clean voided specimen, then it's going to be at least an hour before you can get a dirty urine. So I ask Tessa to hold off, and I see those people first and then decide whether they need dirty urine, clean urine, or possibly both, because if they do the dirty urine and then clean themselves off and urinate a little bit, they can actually give you a midstream test as well. Syphilis is uncommon. You do see it in men that have sex with men occasionally now, so may be worth testing. It's not a terribly expensive test, and usually we'll just go ahead and do it, but it is not something that you should have a high threshold of suspicion for. Viral hepatitis, especially hepatitis B and hepatitis C, definitely you want to do testing. Hepatitis B surface antigen is enough to see if somebody's infectious, as well as hepatitis C antibody. Those are usually the screening tests that we do. Herpes testing is somewhat controversial, may have some benefits, especially in somebody that wants to be able to certify that they're completely clean and start a new relationship. But we will accede to their wishes depending on what they want to have done. One of the slides previous did have some stuff on strep. Obviously, group A beta hemolytic strep is the concern as far as strep throats and as far as causing rheumatic fever. We'll talk more about these when we talk about ear, nose, and throat infections. This concludes the infectious disease talks. Obviously, there's a lot more infectious disease information that you can look into, but this has hit the highlights. Any suggestions for additions in the future, let me know.